This is Dr. Benner, and this is the Shelbourne Knee Center podcast. Thank you for joining us. If you want to see us on social media, you can find us on Instagram or Twitter at the SKC Podcast. You can visit our Facebook and YouTube pages for the Shelbourne Knee Center podcast, or if you need to contact us by email, you can do so at the skcpodcast@gmail.com. If you like what you hear and you've heard our previous content, leave us a 5-star review and a comment so others that come behind you can enjoy as well.
And tonight we have another Patient's Place episode. And for those of you that are unfamiliar with the Patient's Place series, this is more of a patient-focused episode that's used as an educational resource for patients to go back and listen to information about whatever diagnosis they may have heard they had at a doctor's visit, or maybe something you listen to preemptively before you go to the doctor as you're experiencing some knee pain. So again, these are more of the patient-focused episodes on top of our other episodes that are more clinician-focused. So tonight's episode, we're going to be covering lateral meniscus tears. We have covered medial meniscus tears in a previous Patient's Place episode, so if that's more of the condition, you can go back and listen to that episode. But specifically for tonight, we're going to be focusing on lateral meniscus tears. So to jump right in here, Dr. Benner, can you talk a little bit about the mechanism of injury, if there is an injury, or is this more of a chronic condition, or really what brings the patients in when you diagnose them with a lateral meniscus tear?
Well, as with everything we do, most patients come in with pain. That's almost always their main complaint. But in the lateral meniscus in particular, sometimes we'll have some locking episodes as well. People will notice locking or clicking on the outside part of the knee. Sometimes they can notice some swelling over the outside part of the knee, which can be caused by a meniscal cyst, which we'll talk about a little bit more, but the vast majority of them come in with pain at their lateral joint line. As far as the mechanism of injury goes, there's multiple different types of lateral meniscus tears, and each one of them comes with their own specific mechanism of injury or common place in the knee that it hurts, or common activities that they have that exacerbate it and make it more symptomatic. So those are the kind of things that we have to understand when we're trying to take care of lateral meniscus tears and apply that pattern recognition as the patients come in and see us.
And talk about pattern recognition of pain or clicking on the outside of the knee. Do you typically see this as a one-time injury that patients have that they come in afterwards, or is this, hey doc, my knee's been hurting for 6 or 8 weeks and now I'm seeing you type thing?
Yeah, most of these, especially in younger people, are injury related. For middle third lateral meniscus tears, sometimes they'll land from a jump or from a hard step and feel the knee go inward a little bit and feel a pop on the outside of the knee, and that usually can tip us off that they may have injured their lateral meniscus. As far as the tears more in the back of the knee, sometimes it can be more positional related. So people say, when I put my leg in a figure 4 position, I felt a pop on the outside of my knee or felt a lock. Sometimes some sort of locking episode. Sometimes with squatting, then people can say, well, I felt when I squatted down, I felt like something came out of place. And as I came up out of my squatting position, I felt something felt like it popped back into place. And then once it was back in place, I felt like I could move my knee more, in a normal fluid manner. So those kind of things are, pretty specific to those types of tears.
Are there any certain populations that you see this more prevalent in, whether that be the younger athletic population playing a certain sport, or more of somebody in a particular career that may make them more susceptible to this?
I mean, the majority of lateral meniscus tears happen at the time of ACL injuries. I would say most of the ones we see, now they're not necessarily symptomatic, separate from the ACL tear, but they do happen pretty commonly, since we know that giving way episode and that anteriorly directed displacement of the knee, of the tibia, happens during an ACL injury. Principally happens on the lateral side of the knee. So we do see tears there. But as far as isolated lateral meniscus tears, there's a younger population that will get a specific type of tear, such as a middle third tear or that posterior horn, kind of displacement tear. And then there's a tear that happens in the anterior, the front part of the meniscus, that happens more in an elderly population. So it all depends on the type of tear, which of those, kind of history and mechanism of injury we see.
So once the patient does sustain this type of injury and they have that lateral or outside of the knee pain and clicking and they come to see you, what is something that they should expect from an examination standpoint?
Well, we always start with the history. We always want to talk to them about how when they started to have pain, how long it's been bothering them, how bad the pain is, and then some of those aspects that I talked about before. Was this a normal knee that then had a specific injury, or was this a knee that has been bothering you for a long period of time that kind of came on more insidiously or a little bit at a time? Do we ask about the details of the injury? Did you feel which direction the knee went, or did you get hit by something? Was your foot planted or off the ground? All those kind of the normal history things that we take for almost any knee injury before we move on to physical exams. So hopefully by the time we're actually laying hands on the knee, hopefully we have at least a provisional diagnosis in mind based on what the patient tells us.
And then as you go into your physical exam, is that any different for a lateral meniscus tear when you're suspecting that compared to any other knee condition a patient's going to come in with?
Well, the general stuff is the same. We always we always go to the opposite knee first, to the uninjured knee first, and check the range of motion, see what their normal degree of hyperextension and flexion are on the uninjured knee, if they have an uninjured knee, and then apply that to the injured side to see if they have any range of motion loss. Once we do that, then I put the knee up at 90 degrees and start palpating the knee. And if the patient's told me, whatever side the patient has told me that the knee hurts on, I try to examine that area last. So if I have a patient that complains of lateral knee pain, I'll put the knee at 90 degrees after I've checked range of motion, and I'll push directly on the patella tendon, maybe on the patella itself, see if they have any pain in that area. Then we'll go to the medial parapatellar area and around to the medial joint line, all the way back to the posterior medial joint line. And I'm basically just trying to palpate the patient with a pretty standard amount of pressure with my thumb, just with one finger, and get a lot of no's. Does it hurt here? No. How about here? No. How about here? No. How about here? No. Just to establish that they're not having pain in other places, or that they're not just particularly sensitive to and tender with touch. And then we always go to the injured area last. So then I'll go to the lateral parapatellar area and then around to the lateral joint line and take note of, do they have tenderness in that area? And if so, what part of the lateral joint line? Because up in the front of the joint line be more kind of anterior horn degenerative tears of the lateral meniscus. Around to the middle third, those are more likely to be radial or radial flap tears of the meniscus. And then more posteriorly, vertical tears that can cause displacement of the lateral meniscus. So I'm always going to push around on the joint lines, compare it side to side, check the range of motion when we talk about physical exam. And then specific to lateral meniscus tears, I also want to do a McMurray's test where we hyperflex the knee, flex the knee all the way up. I kind of wrap my hand around the knee, so my middle finger is on the medial joint line, my thumb is on the lateral joint line, and then turn the knee for the lateral meniscus into external rotation, a little bit of varus or kind of bow-legged push to push the knee out to the side, and then extend the knee while I have it in that position. And in that position, if we feel a click or a pop, or just if the patient has pain in that area, we consider that a positive McMurray's test, where we're trying to trap the lateral meniscus between the two bones and get it to pop. And if it does, then that makes me even more suspicious that the lateral meniscus tear could be the diagnosis.
So after a physical exam like that, and you are suspicious that it is going to be a lateral meniscus tear, do you jump right to imaging, or are you pretty confident after the exam that imaging is really unnecessary? What's your plan for that?
We always start with plain x-rays to make sure they don't have any joint space narrowing or loose piece or something, or a fracture or some sort of traumatic injury that we can make the diagnosis of pretty quickly via plain imaging. But assuming that the x-rays are normal, I don't necessarily go on to further imaging after that. There's a lot of factors that play into that, such as, kind of how suspicious I am. If I think there's a small chance they could have a lateral meniscus tear, I may not go to imaging right away, versus if I think there's a very good probability that they probably have a lateral meniscus tear and it's something that may require surgery. I just want to make sure that my MRI scan is really going to guide my treatment. If I think, if we find a lateral meniscus tear with an MRI scan at this point, I'm probably still going to recommend non-surgical treatment, then I don't think there's any reason to get the MRI scan. I think then it's just an academic exercise and it doesn't actually guide our treatment, versus if it's been bothering a patient for a longer period of time, if they're an in-season athlete who I think may need surgery sooner rather than later, or if I think the chances of, surgical intervention in the near future, then I'll go ahead and move on to MRI scans.
Now, in that answer you just gave, you mentioned two care pathways. You talked about non-operative treatment as well as surgical treatment. What is the deciding factor between those two? Is it one before the other? Is it 100% of the time non-operative treatment until proven otherwise, and then it's going to be a surgical case, or do you ever jump right to surgery? So, and that's I guess my first question is what's your thought process with those two pathways, and then the main question is what factors are you assessing to make you decide between which pathway or the other?
Well, when it comes to lateral meniscus tears, the only time that we'll really go immediately to surgery, for the most part, is if they have a displaced lateral meniscus tear. So, on the lateral side of the knee, with a lot of flexion, hyperflexion injury, or figure four position where you get your knee in kind of an awkward position, the lateral meniscus kind of gets trapped between the two bones, and the back of the lateral meniscus actually displaces up into the front of the knee. That can cause the knee to become locked to where it's stuck at sometimes 15, 20 degrees of flexion or more, and the patient can't get their knee straight. And in that case, we can't leave the knee locked like that for a long period of time because it'll get really stiff and then it's very difficult for the patient to get around. So in that case, where we think we have a displaced meniscus that is stuck up in the front of the knee and the knee's locked, then we will proceed on to MRI scan from the very beginning and plan on acute surgical intervention. Other than that, usually it's a little more of a work in progress as far as working towards potential surgery for a lateral meniscus tear. We do take into account whether or not the patient's an in-season athlete and where they are in relation to their athletic participation. So if an athlete comes to me with 2 weeks to go in a season, it's their last season, they say, I got to finish out my season, I think I can play with this lateral meniscus tear, and they're not locked, then we will a lot of times say, you know what, finish your season, try to get by as best you can. And if you can finish out your season, maybe we'll take care of it after the season where you won't miss athletic participation. Versus if they're an in-season athlete, especially if it's early on in the season, lateral meniscus tears can often get back to play within, a month or so, sometimes even faster for in-season athletes that want to get back quickly. And if that's the case, we don't want to spend a lot of time on non-surgical treatment and end up delaying their return to play till it's too late and they miss a lot of time. Especially one of my least favorite times a year is right before football season, because, in football camp, if somebody, is a collegiate football player and they think they have what you think is a lateral meniscus tear, that turns into a 5-alarm fire because they don't want to wait around for another 6 weeks, see things get better with surgery, then get an MRI scan, then make a decision on surgery, then have a surgery and a recovery and miss a lot of their season. In that case, we do move a little bit faster and go to imaging a little bit earlier. And if they have a lateral meniscus tear, potentially do a partial lateral meniscectomy so they can get back to sports within 3 or 4 weeks and not miss as much of the season. But for the most part, for the vast majority of our patients, we are going to try to get the knee better non-surgically in some way before we move on to imaging and or surgical intervention.
Scenarios. One is the non-operative path and one is the surgical path. And starting with the definitely less invasive, but potentially less complicated of the two, with the non-operative path, what are some things that you are hoping to get out of that? I'm assuming you're going to send them to physical therapy and you're going to work on what? And what are your goals for that patient non-operatively?
For the majority of the patients with lateral meniscus tears, there are really three main varieties of lateral meniscus tear. If you take the ACL reconstruction, the ones that happen at the time of ACL surgery out of the equation, and each of those plays a little differently with regard to whether we're going to recommend surgical intervention, and if we don't recommend surgical intervention, what kind of non-surgical treatment we're going to do, to your point. So if we start with anterior horn tears of the lateral meniscus are usually degenerative in nature. They kind of come on slowly and kind of insidiously without a specific injury. They generally happen in the elderly, a little bit more common in females than males, and they hurt specifically in the front of the joint line with terminal extension, with full hyperextension. So in that case, if the patient has been having pain with full extension and they lose extension where their knee is stiff with a flexion contracture, then we'll try a period of physical therapy to improve range of motion and eventually get their strength back. That can be particularly difficult when extension is what makes it hurt in the first place. But if you can get it calmed down with anti-inflammatory medicines, with steroids, with injections, and the tear kind of calms down a little bit, then we're really working on that extension range of motion. On the flip side, if somebody has a vertical tear of the back of the lateral meniscus, one where it's immobile and it can potentially lock and displace, if the meniscus partially displaces and then pops back into place, that does have an opportunity to heal. And if that's the case, you just want to make sure you get their range of motion back again. However, in that case, it's flexion that really, when you bend the knee really deeply, that puts a lot of pressure on the place where the tear is most likely to hurt. And sometimes they can lose flexion. So once that's kind of calmed down and healed, then you really got to get their flexion back. And then with any knee problem, we always want to get the extension back first and maintain that, then get the flexion back. Once the flexion's back, start some light exercise, biking, elliptical, machine, Stairmaster, things like that, swimming, things like that, to kind of get the musculature around the knee really moving. And then eventually we test the strength over in our gym, try to equalize it versus the opposite side, and then hope it hits benchmarks for pre-injury and towards body weight. And that's really the same kind of therapy pathway that we follow for any knee problem, and it definitely plays in with non-surgical treatment of lateral meniscus tears as well.
Now, me being a physical therapist and seeing these patients when you were prescribing them for therapy and seeing them non-operatively, obviously there's a tear. And one of the most common questions we got when you're treating somebody with something of a structural tear, like a lateral meniscus tear, and you're treating it non-operatively, a lot of times the patients ask, well, am I doing any more damage? Am I tearing it more? And then I'm glad you mentioned the healing potential of the lateral meniscus for at least one of the varieties, and you're trying to allow it time to heal. Is that something you're concerned about? Do you educate your patients on either A, you need to wait till it heals, or B, you need to worry about this not tearing more, or does that even matter? What's your education for your patients on that?
In the setting of an ACL intact knee, I would say the short answer is no. I don't think the time to intervention surgically is going to really make a difference in things. With an ACL tear, if you put off surgery, you continue to have giving way episodes or even micro levels of instability where the knee's a little bit unstable, and you keep putting pressure on that meniscus tear over and over and over again, then you could allow that meniscus tear to get larger over time and be more likely to need to have a partial meniscectomy. There have been multiple studies over time that have shown that delayed surgical treatment of ACL tears can cause some meniscus tears to get worse. But in general, if you have an ACL intact knee and you have one of those three main types that I described, this is all happening in the setting of an otherwise normal knee. So if it's tearing like that with normal daily activities, I find it difficult to tell patients that there's anything they're going to do to keep it from tearing worse. So most of the patients in that type of scenario, I will tell, if the meniscus is torn, it very well may not heal, but hopefully the symptoms will potentially calm down. But I don't think there's anything you necessarily have to do or not do in order to keep it from happening, because, as we all live our lives, you can't just say, well, don't bend your knee past 110 degrees for the rest of your life, because that's going to put stress on the back of the meniscus and make your meniscus tear potentially. That's just not practical to do. So in general, I don't think avoiding certain activities is really a part of, meniscus treatment for the most part.
I guess when it comes to surgery, what are you shooting for? I know you mentioned meniscectomy. Is that something where you're trying to excise the tear, or is this a tear that you're trying to repair?
And for degenerative tears up in the front of the meniscus, definitely doing any surgery would be to remove the tear in the front of the meniscus on the lateral side. For middle third radial tears, some people do advocate fixing those. I find those to be difficult to get them to heal because they're more radial in nature. They're kind of going from the less vascularized part of the meniscus, the part of the meniscus without as much blood supply, and then kind of form a little bit of a flap. And I think even if you can stitch it back in place, I just don't think the biology is there to really make that a good outcome for us. So most of the time we'll take middle third tears out as well. Sometimes you can also develop a horizontal tear in the middle third of the meniscus. Those are the ones that can form meniscus cysts. We talked about that a little bit earlier, but they kind of separate into top and bottom halves where there's a tear horizontally in the middle of the meniscus. Then joint fluid sometimes can get between those two layers of the meniscus and then kind of heal around the end of it and form a small cyst on the outside. So in that case, you do have to take out one of the sides of that tear, or there's still going to be a potential for the tear to kind of close around joint fluid and make the cyst worse, versus if you take the bottom half of the meniscus, the more degenerative portion of the tear out, then there's not really a way for that to happen anymore. For those posterior ones that are vertical in nature and are displacing up into the front of the meniscus, if there's an intact ACL, those are some of the few meniscus tears that I do think are worth fixing, because in most cases those are kind of pretty normal meniscus that just got trapped in a very uncommon position. And I think there's a good chance, since the tear is more peripheral and vertical and in the back of the meniscus where there's better blood supply, I think that at least has a chance to heal. So if a patient has the displaceable lateral meniscus that goes back into where it's supposed to be, and we can try to give it some time until it heals and treat it non-surgically, then we can do that. However, if it gets stuck up in the front of the knee, or if it's a big enough tear that it pops multiple times and continues to lock on the patient, then that's where we will go ahead and do a meniscus repair. When it comes to meniscus repairs, I like inside out technique. It's kind of maybe a little more of an old school way to fix it, but I think it's the strongest fixation that we get around that tear. The incisions are pretty small. It's not that invasive of a procedure, and it doesn't use any meniscal, fixation devices. Sometimes those all suture devices, or suture and some sort of other device to kind of grab on the back of the meniscus and tighten suture around it. Sometimes I've had those that they kind of dislodge when you try to put them in, or after they're already in, then the larger like anchor portion can become displaced inside the knee and float around inside the knee. I just don't like the intra-articular devices as much. I like to put the stitches in arthroscopically, retrieve them through a small incision on the lateral side, and do more of what's called an inside-out repair.
Now, the two techniques that you mentioned, the repair and the meniscectomy, what does your postoperative rehab look like for those two? Is it any different based on repair and meniscectomy, or is it the same?
The short answer for us is no, but the longer answer is we don't usually restrict people from weight bearing or range of motion after meniscus repair, because we only fix tears that we believe are likely to heal under those conditions. So the vertical tear at the periphery of the meniscus in the back that's displaceable and is locking inside the knee, once we put that back in place, we put some stitches up near the front of the tear to convert it from a large tear that's displaceable to a smaller tear that's not displaceable. But weight bearing helps to force the meniscus back against the capsule. By putting weight on the knee, the meniscus is kind of wedge shaped, and it can push the meniscus out against the capsule, which is where the coverings around the knee, where the blood supply is. So we like to encourage actually weight bearing in that way with meniscus repairs that we do. Same thing with range of motion. If we thought that the range of motion was going to displace the tear to the point where it wouldn't heal, then I wouldn't recommend repairing it in the first place. In our opinion, if you're going to make the decision that you think it can heal if you stitch it back, then you should go ahead and allow full range of motion of weight bearing from the very beginning. The downside to restricting motion and to restricting weight bearing is an increased recovery time, more time off of athletics, and also it's just makes it more likely to get stiff. And if I've learned anything from my partner, Dr. Shelbourne, the namesake of this podcast, it's that range of motion is really key and kind of king of the road when it comes to knee problems. That if you do anything that makes the knee stiff, you potentially are going to make it worse. And that if you lock a patient up in a brace and make them non-weight bearing, then you're going to make them stiff, weak, and deconditioned, at least temporarily and sometimes permanently.
Now, you said for these patients in our hands, the postoperative rehab is really about the same. In a global sense, what are you looking for from a postoperative rehabilitation goal standpoint? And then second question, what's your prognosis for these patients when the patient is signing up for surgery? A lot of times they're going to ask, well, if let's say they're an athlete, when am I going to get back to sports? Or professionals, when am I going to get back to work? When am I going to get back to my workouts? When am I going to get back to pick up basketball? Those types of things. So first question, what are those global goals you're looking for from a rehab standpoint? And then second, what is the prognosis in terms of time to activity that you tell these patients?
Yeah, we mentioned this a little bit ago. I think the non-surgical pathway and the surgical pathway, in my opinion, are about the same from a rehab standpoint, in that you want to get their extension back, you want to maintain that, get their flexion back, maintain that, start them on some light exercise, maintain that light strengthening, test their strength, equalize their strength, make it normal to body weight. And I think that's the rehab progression that I'm interested in, regardless of what knee problem there is. But specific to meniscus tears, once that, kind of once that, for middle third tears, for example, and in-season athletes, once that flap is gone, the knee really feels better pretty quickly, and they can progress relatively quickly back to sport. Sometimes we'll even get patient back as early as like 3 weeks after surgery, although I would call 4 to 6 weeks a little more the norm with regard to return to play. Now, as far as meniscus repair goes, theoretically that should take longer because we're waiting on things to heal. However, if we're going to do a weight bearing and no restriction on motion protocol like we do, then everything just ends up being dictated in the same way by strength. Once they get their strength back, I think we're going to let them go ahead and play. So the return to sport rates for that procedure, even with fixing it in our hands, is about the same as it is taking it out. Now, if you put the patient in a brace, if you restrict their weight bearing for several weeks, that's definitely going to lengthen their return to play.
Now, earlier in this episode, you had mentioned meniscus cysts. I guess first question is, what are those? And second, how do you treat those? And what's the prognosis for those?
Well, meniscus cysts, kind of by definition, only form because the meniscus is torn. So in order to call something a meniscus cyst, you kind of have to also make the diagnosis of a meniscus tear. And usually the meniscus tears will happen in the middle, that lead to cysts will happen in the middle third of the meniscus, and you'll develop a horizontal separation between a top and bottom layer of the meniscus. Because there's top and bottom layers, then the joint fluid can actually get between the two layers and then get trapped there. And once it does, that fluid just kind of becomes like a jelly-like substance and just kind of stays there. And it can cause some fullness on the outside of the knee. There's not much soft tissue on the outside of the knee, so even getting a relatively small cyst can cause some soft tissue fullness on the outside part of the knee, and the patients don't like the looks of it. You can try to aspirate it. You can try to decompress the cyst by putting a needle in it, maybe even injecting it. However, until the tear goes away, the cyst is probably not going to go away. If it does go away, it could come back and likely won't stay away. So when people have a meniscus cyst, in addition to, getting into the cyst, trying to break up the cyst and getting the cyst contents out of there, you also have to take out the part of the tear which is usually the undersurface half of that tear, which allows fluid to get trapped there. And then once that bottom leaf is gone of the meniscus and there's nothing else to kind of form around the meniscus cyst, then usually the cyst will get better and it will stay away.
Now, going back to that discussion we were having about postoperative rehab and prognosis in terms of return to sport, you said the timeline of typical of 4 to 6 weeks potentially. Is there anything the patients should look out for at the time of return to sport? Anything that may set them back or really hurdles that they need to get past before they get back to normal activity?
Yeah, return to sport for lateral meniscus tears is pretty quick. However, you can still struggle even if you do get back to sport. So one thing that happens on the lateral side of the knee, the meniscus is more C-shaped, and that's because it has to really fit the femur and tibia together at the level of the joint line, because both of those cartilage surfaces are relatively rounded. So you have a little bit more of a burden for the meniscus to make those two fit together. So once you take out a part of the lateral meniscus, then you put more round surface on the end of the thigh bone and a rounded surface on the end of the shin bone, kind of opposing one another. And without that meniscus there, it does cause some wear and tear to the cartilage as it kind of wears into a new relationship between those. With that little bit of wear and tear that happens after you take a part of the meniscus out, usually comes some swelling. So we got to make sure that we educate our patients on the front end. We're going to take this meniscus tear out. You're probably going to get back to playing sports relatively quickly within the matter of a few weeks. However, once you get back, we got to make sure we're doing maintenance work for swelling control and that we expect that the knee is going to get swollen. If you don't tell your patients about that, then my experience is they go back to play, they feel good. After a few weeks, they come back and say, I don't know what's going on, but my knee's all swollen and it wasn't swollen before. It's not necessarily painful. It's usually painless swelling, but they do often get swollen when they go back. So it's important to counsel our patients. Once this meniscus is out, you'll be back to playing, but we got to do something on a maintenance basis to control swelling. We got to know that you're going to potentially have some painless swelling for several weeks after you go back the first year that you go back, but in the long term, that won't necessarily be the case. And then as far as x-rays go, over time, you can see a little bit of lateral joint space narrowing. When we've looked at it before, we find about 1 or 2 millimeters of lateral joint space narrowing that happens in the first year or two after surgery. And then after that, it kind of stabilizes. So it's important to tell the patients if they ever to get x-rays again, they're probably going to have a little bit of lateral sided wear.
Going back to that swelling at the time of return to sport, you say that that's pretty typical for patients with the lateral meniscus tear. And knowing that it's happening around that time of return to sport, how much swelling is too much swelling? Or what do you counsel those patients? Can you play on that swelling? Do you have to wait till it goes down? Obviously, you're practicing some principles to get it down, but they might have a game on Friday night and their knee swells up on Thursday. What do you tell these patients in terms of, even though it's expected, can they play on it or no?
Yeah, I tell them, we want to keep it at a manageable level. So if you go out and you have a practice and your knee gets swollen, and then after practice you put your cryo cuff on, you ice down, you take it easy that night, you wake up the next morning, then the swelling's kind of back down or near back down to where it was before. I think that's something that everybody has to go through when they go back from a knee injury to playing sports, but specifically when we've done anything to the lateral meniscus. What you don't want to do is let it really get out of hand. If usually it's painless. If it's painful, then that's a different story. And if you keep having these cycles of the knee gets swollen with activity and you try to get off of it, but then it gets more swollen the next day with activity, more swollen with the next day for activity, then you may have to back activities off to every other day or make some sort of alteration to make sure that the swelling doesn't get too bad. But if it's at a relatively mild level, if it's not painful, if it doesn't restrict your range of motion, then it is okay to go ahead and play through it and just know that, you've been told that that can't happen and that's pretty normal.
Great. Well, that was all a ton of information, a lot of good information. And like the other Patient's Place episodes, perfect information for the patient. So if you're a patient and need more information, come check out these Patient's Place episodes, or if you're a physician and wanting to look for resources for patients to go to, check out these Patient's Place episodes. If you want to reach out to us, you can hit us on our socials on Twitter and Instagram at the SKC Podcast, on our YouTube and Facebook SKC Podcast pages, or email us at the skcpodcast@gmail.com.
As always, our Patient's Place episodes are for educational and learning purposes only. If you have any specific questions about your care, we encourage you to reach out to your surgeon for more information.